Welcome to our video on primary adrenal insufficiency. Let's get started. Here is our overview slide. Let's begin by discussing the definition. Primary adrenal insufficiency is characterized by insufficient production of hormones by the adrenal gland. There are two major subtypes, acute adrenal insufficiency and chronic adrenal insufficiency, which is also known as Addison disease. There are three key etiologies of acute adrenal insufficiency. First is sudden cessation of chronic corticosteroid therapy. This is because prolonged use of exogenous steroids leads to suppression of ACTH and subsequent atrophy of the adrenal glands, which makes them unable to produce corticosteroids on their own. Second is treatment of Cushing's syndrome, as the medication used in treatment either prevents production of steroids or directly antagonizes corticosteroid receptors. Third and last is Waterhouse-Friderichsen syndrome, which is a syndrome characterized by adrenal hemorrhage and loss of function secondary to a bacterial infection with Neisseria meningitidis. Chronic adrenal insufficiency also has three key etiologies. First is autoimmune adrenalitis, or autoimmune destruction of the adrenal glands, which is common in the developed parts of the world, such as North America. Second is tuberculosis adrenalitis, or destruction of the adrenal glands by Mycobacterium tuberculosis, which is common in the developing parts of the world. And third is metastases to the adrenal gland, which usually occurs in the setting of lung cancer. The clinical features of acute adrenal insufficiency are collectively known as an adrenal crisis, and they include profound hypotension, altered mental status, abdominal pain, and shock. All of these clinical features have to do with an acute drop in systemic levels of steroids. Clinical features of chronic adrenal insufficiency, on the other hand, are less severe. Patients usually present with weakness, weight loss, and gastrointestinal symptoms such as nausea or abdominal pain. Patients may also present with postural hypotension, salt craving, and hyperpigmentation of the skin. Here's an image of a patient with known Addison disease. Note the characteristic hyperpigmentation around her knees. All right, let's try a question. Why do patients with Addison disease experience hyperpigmentation of their skin? Put simply, patients with Addison disease cannot make a sufficient amount of corticosteroids like cortisol. Low levels of cortisol trigger the pituitary gland to produce more ACTH. A byproduct of ACTH is a molecule known as MSH, which stands for melanocyte stimulating hormone. Therefore, increased levels of ACTH will be accompanied by increased levels of MSH, which will increase the extent of skin pigmentation. As part of the diagnosis, clinicians may obtain a morning serum or salivary cortisol, which will be low in patients with primary adrenal insufficiency, since the adrenal glands cannot produce cortisol as they normally would. Clinicians may also obtain a plasma ACTH, which will be high because adrenal glands cannot make cortisol, and the pituitary will keep releasing ACTH in response to the low cortisol levels. Lastly, clinicians may order an ACTH stim test, also known as a cosentropin test. And during this test, clinicians give the patients exogenous ACTH and then measure the serum cortisol levels. In patients with functional adrenal glands, exogenous ACTH will stimulate them to produce more cortisol, leading to an increase in serum cortisol. In patients with primary adrenal insufficiency, on the other hand, there will be little to no increase in serum cortisol in response to the exogenous ACTH. Although not diagnostic of primary adrenal insufficiency, there are several additional laboratory findings that are worth mentioning. As mentioned earlier, steroids have intrinsic mineralocorticoid activity. In other words, they have functions similar to that of aldosterone. This is why a deficiency of steroids may lead to euvolemic hypotonic hyponatremia, hyperkalemia, elevated serum ADH, and an anion gap metabolic acidosis. In addition to having intrinsic mineralocorticoid activity, steroids also stimulate apoptosis of eosinophils. Hence, without steroids, eosinophils are less likely to undergo apoptosis, which may result in eosinophilia. The management of primary adrenal insufficiency is straightforward. Simply replace what the adrenal glands can no longer make. This includes glucocorticoids, which can be replaced with hydrocortisone, and mineralocorticoids, which can be replaced with fludrocortisone. Lastly, consider giving IV fluids such as normal saline or LR to patients in an adrenal crisis. All right, let's wrap up with the final question. What is the most common cause of chronic primary adrenal insufficiency in the United States? All right, the correct answer here is autoimmune adrenalitis. So be sure to look for this condition in patients who are at higher risk for developing autoimmune conditions. On the boards, these are usually young women. And that concludes this section.